Hello, can people hear me? So I'm just having some technical issues on this end. I'm going to try and upload the PowerPoint and I'll get started shortly. Okay, so I'm going to try sharing my screen. Can someone give me a thumbs up or something if this is if you can hear me now, please? Great, thank you. Okay, excellent. So can you see the slides here? Someone could put a thumbs up in the chat, that would be great. Excellent, thank you so much. Um, okay, so welcome to the OSME talk on depression and anxiety. This is just going to be a quick overview, a run through of the revision on these two topics. Um, so just for some background, I'm a graduate entry medical student at Oxford, and yeah, hope to just take you through these few cases. We've got an overview, look at some of the different types of depression and anxiety and categorization of the disorders, how we go about diagnosis, management, and then some more special scenarios. So looking at pregnancy, pediatrics, um, that kind of thing, and how that might impact management. Um, so both depression and anxiety are extremely common. We've got some statistics up there as to quite how common, and actually they coexist together really quite frequently. And I mean, looking at the days lost from work just in the UK, 1 in 5 of days lost from work is due to depression and or anxiety. Um, and just flagging up that if you are considering one of these um, in a patient, then it might be a good idea to consider the diagnosis of the second as well, because they do coexist and the symptoms do interact. Looking at prevalence, the main peaks are between 45 to 59 years old. This is of depression. They increased quite significantly during the pandemic, and that was especially true in children and adolescents as well. Um, they are now seeming to decline, which is good, but we do still want to be really alert as to how that and those types of situations, uncertainty, social isolation, that type of thing can contribute to an increased prevalence of depression. Specific symptoms to be looking out for: continuous low mood, low self-esteem, guilt, anhedonia, so lack of enjoying things that you would normally enjoy, irritability. I mean, I don't need to read the list there for you, but some other ones that are not on the list are changes in relationships. So here it's got avoiding social contact, but people having particular social difficulties, finding their speech and movement is slow. Loss of libido is something that people can struggle to bring up in consultations, so could be worth asking about once you've built some rapport. And self-neglect is one of the things that you might first think about when someone presents, if you're thinking of doing a mental health assessment: appearance, behavior, that kind of thing, and just checking in on how patients are doing day to day in terms of self-care. Super important in terms of considering whether a patient might have depression. Looking at anxiety, has a slightly younger age of highest prevalence, so 16 to 29-year-olds, with women having a higher prevalence than men. Again, prevalence rose during the pandemic and does now seem to be declining. Compared to depression, the main symptoms of anxiety: restlessness, irritability, and fatigue, which are both the same as depression. Difficulty concentrating, difficulty getting to sleep and staying asleep, and tense muscles. Some of these very much overlap with the depression, and some of them almost contrast with the depression. So especially if you're looking at co-prevalence, then it's interesting to see in which patients which symptoms arise. So just keep an eye out for both at the same time. Various different types of depression, major depressive disorder being the main one that we'll focus on in this lecture, alongside generalized anxiety. There's also persistent depressive disorder, which is over 2 years. For major depressive disorder, we'd be looking for symptoms to be lasting at least 2 weeks. So if someone comes in with low mood for a few days, that might not quite qualify, but could, book a follow-up appointment. And if it's been persistent for over 2 weeks, we'd think about a diagnosis and some intervention. In children and adolescents, we might also be looking at disruptive mood dysregulation. And also important to think about more particular cases, so premenstrual dysphoric disorder and postnatal depression. With regards to that last one, baby blues tend to be, that's when the woman that's just given birth may be feeling quite tearful, irritable, feeling quite low. That usually lasts for the first few days after pregnancy and after childbirth. But beyond 2 weeks, we might want to be thinking about postnatal depression, seasonal affective disorder, and substance and medication-induced depressive disorder, also 2 other variations of depression. Looking at generalized anxiety disorder, this is the main one that we're going to be addressing, looking at for this lecture, but there are other specific types of anxiety disorder. And within the DSM-5, things like eating disorders tend to fall under anxiety type disorders as well. So for GAD, we'd be looking at people experiencing symptoms persistently, so worry, fatigue, difficulty concentrating, and some systemic symptoms as well. So GI symptoms, sweating, palpitations. I'll go into the treatment a bit more specifically further into the lecture, but predominantly looking at SSRIs, although beta blockers can be considered as well for things like panic attacks. Post-traumatic stress disorder usually is diagnosed over 4 weeks after a particularly distressing life event. Within the first 4 weeks, you'll be looking at an acute stress response rather than PTSD itself. Key features tend to be feeling emotional dysregulation, negative self-perception, and quite distinctively re-experiencing of the traumatic event. And that can be triggered by something during the day, or also can present itself through nightmares and dissociation as well. Treatment for PTSD is through EMDR, so that's eye movement desensitization and reprocessing, which I'll talk about a little bit later, and cognitive behavioral therapy, which I'll also talk about in a little bit. Obsessive compulsive disorder is another type of anxiety disorder that we might want to consider, especially if someone has compulsions, which are leading them to perform ritualistic type behaviors to make them feel, which it makes the obsessions and the obsessive thoughts ease for a little bit, but then they need to be repeated continually. So things like turning off light switches, checking doors are locked, that kind of thing. Treatment is CBT and fluoxetine, which is another type of SSRI, which I'll talk about again a little bit later. And then the final type of anxiety that I'll touch on briefly is panic attacks. So this might be something that presents in the emergency department, for instance. Patient may feel like they're going to die. These can be very predictable, very unpredictable even, and they might have recurrent episodes of this. If untreated, it can lead to generalized anxiety disorder, but the mainstays of treatment are around psychoeducation and cognitive behavioral therapy. Diagnosis of depression, the best screening tools so far are depression questionnaires. The PHQ-9 is kind of the mainstay and the first line of thinking. It involves 9 questions, which classify symptoms on a scale of 0 to 3. And then at various cutoff points on that scale between 0 and 27, will categorize between mild, moderate, and severe depression, and that helps you to angle treatment. In terms of coexisting anxiety and depression, if you only want the patient to have to fill in one form, then it might be better to look at the hospital anxiety and depression scale, since that ranks both symptoms of anxiety and depression. And there's also the Beck Depression Inventory, just as some variety. So there are several different tools that can be used here. Super important when a patient comes in with non-specific symptoms is to keep depression in mind as a differential, but also other differentials as well. A lot of the multiple choice questions that I've seen, especially in the psychiatry part, at least of PassMed, focus on elderly patients coming in, potentially with some memory loss, general low mood, fatigue, and loss of interest in activities that they used to enjoy, which may initially strike tones of dementia or early onset dementia, but we really should be considering depression in these cases as well, especially if there is social isolation or any bereavement, anything like that, that could be actually flagging you more towards depression diagnosis. Also, it's important in all age categories to be ruling out other differentials. So looking at things like iron deficiency anemia, low B12 or folate, which can be causing the low mood and fatigue and difficulty with sleep, hypothyroidism, and even viral infections like mononucleosis, which can be causing that fatigue, low mood, and lack of interest in doing other things. Diagnosis of anxiety tends to be using the GAD-7 questionnaire. So I've got the 7 main questions up here that you would be asking a patient over the last 2 weeks. How often have you felt bothered by? And then these 7 points. Similar to the depression scales, this is rated from 0 to 3, with 5, 10, and 15 being cut-off points for mild, moderate, and severe anxiety. The neurobiology of depression and anxiety is not fully well understood. The mainstays are around looking at neurotransmitters, so serotonin, noradrenaline, and dopamine. Historically, as of the last few decades, people have really been looking at these neurotransmitters, and obviously the use of SSRIs, which is selective serotonin reuptake inhibitors, and SNRIs, selective noradrenaline reuptake inhibitors. They are the cornerstones of treatment. And there's been lots of research into how different types of receptors may be more or less effective in being preventative against depression. Actually, more recently, we're looking at, the medical profession and research institutes seem to be looking more at a circuit-based approach. So rather than looking at specific neurotransmitters, actually looking at the circuits within the brain, so brain regions including the amygdala, hippocampus, and prefrontal cortex, and how these work together more widely and communicate with each other, and how they might, it's about the communication between those networks that might cause and promote depression and anxiety, rather than there being a distinct increase or decrease in a specific neurotransmitter. I think one particularly key case recently looked at the amount of serotonin and the levels of serotonin in the synapses of people with depression, and found that they didn't have as low levels as might be expected. But I think there was a big media campaign around whether that may or may not mean that SSRIs should be being used or are as effective as we hope that they are. I think, in fact, just because we don't necessarily know the cause, we can see that SSRIs are extremely beneficial in many cases for people with both depression and anxiety. So not necessarily completely understanding the neurobiology behind these conditions at the moment shouldn't be stopping us from using effective treatments that we can see through evidence-based medicine work to help patients feel better. And the final neurobiological aspect that, again, super important to mention is the neuroendocrine factors. So the hypothalamic pituitary adrenal axis, obviously previously I said to screen for hypothyroidism in people that might have depression. Also thinking about other hormones as well. So, we've said postnatal depression and obviously depression during pregnancy, and especially during teenage years as well, when hormonal fluctuations are potentially impacting mood more than they might otherwise. So important to take a wider lens of understanding when looking at the neurobiology of depression than just thinking, oh, serotonin and dopamine. It's much wider than that and more complex. Management of depression. Most of these I've taken from the CKS, so the clinical knowledge summaries pages, which are the NICE guidelines for how we should manage these types of conditions. First line, you want to be communicating the diagnosis, being really empathetic, and also aware of how different people might already perceive depression and indeed anxiety. So that includes cultural aspects and how people might feel about seeking help, support, and even medication for these types of conditions. So being sensitive around that and building rapport, making sure that the patient knows that they can come back to you with no judgment, and trying to be really open around how things like even lifestyle advice and wellbeing activities can be a really useful first step and first line treatment. Pointing people towards social support is also extremely useful, especially if there are other people around, so vulnerable adults and children that might need safeguarding. Just be really aware of also like domestic abuse cases and whether people feel safe at home, and urgently refer to crisis mental health teams if there is a concerning risk of self-harm or suicide, harm to others, self-neglect, or psychotic symptoms. Managing a new episode of depression. The first line is guided self-help and lifestyle advice, things around sleep hygiene, maintaining a circadian rhythm, good nutrition, that type of thing. If the patient requests or feels that they could benefit from medication, first line is SSRIs. Some SNRIs are recommended in cases of severe depression as well. Cognitive behavioral therapy is probably the predominant type of therapy that's considered here, but also group mindfulness, group exercise, meditation and counseling. A recommended review is 2 to 4 weeks after starting treatment, but I'll talk a little bit more about starting SSRIs going forwards in some of the future slides. Starting antidepressants. So number one is to address risk. So we want to be doing good and never causing harm. Number one is to avoid tricyclic antidepressants, mainly due to the risk in overdose, and also possibly considering limiting the quantity of medication prescribed at once if you think there might be a risk of overdose. And then, of course, if a patient is presenting after having self-harmed through self-poisoning, then checking ToxBase and getting in touch with the relative members of the MDT as appropriate. With starting SSRIs, it's useful to counsel patients as to, they have good tolerability, a good safety profile. There are some drug interactions that I'll go into in a little bit that especially come up in MCQs. I think there's mainly triptans is the one that I've seen mostly, but important to remember as well that NSAIDs and other anti-inflammatories as well might have GI complications if used alongside SSRIs. Looking at chronic physical health conditions, so sertraline has fewer drug interactions, so maybe a better place to start than Prozac or fluoxetine. And then it's super important as well in an OSCE scenario and with patients in general to advise them in that first week that levels of anxiety and agitation may well increase on taking serotonin or SSRIs. So it's important to arrange a crisis plan, identify any potential triggers that might prompt someone in that first week, and safety net them so they know they can come back and they know where to go should they get increased suicidal ideation in that first week. Specifically in younger people, I think this has been shown to be more of a problem. So especially in that age ranges, 18 through to 30-year-olds, being really cautious around that first week and having a follow-up appointment within that first week with them. Medication starts to work within 4 weeks, but it's recommended that once it has started to work and symptoms have remitted, it's best to stay on medication for 6 months before starting to come off that medication in order to avoid relapse. This is a massive information overload slide, but I've tried to highlight the key points in here. So as I mentioned earlier, using NSAIDs alongside SSRIs can increase risk of GI bleeding. So if it's a must, and it's then best to do so offering gastroprotection, and that's the same for aspirin. Also, just around the use of anti-epileptic drugs and SSRIs. SSRIs do tend to lower seizure thresholds, so you might want to consider talking with the epilepsy team around whether depression might be worsened by using an anti-epileptic drug, and also whether lowering the seizure threshold is safe for that patient. MAO-B inhibitors like selegiline and rasagiline, since they also work on a mechanism that increases the amount of available serotonin in the synapses, might predispose someone to serotonin syndrome if you were to also then prescribe them an SSRI. So could be better to use an alternative antidepressant in one of those scenarios. Triptans, such as sumatriptan, are used for migraines and also work via serotonin. So again, tend to be try to avoid co-prescribing triptans with SSRIs where possible. Anxiety management, similarly to depression, that first step is rapport, communication, and providing the resources to help support that person, and being really clear around what the symptoms of anxiety are and why they might be experiencing them, and to be completely avoid any stigma around the diagnosis of anxiety and indeed mental health conditions in general. Suitable follow-up and monitoring at appropriate time intervals, and where depression is also being diagnosed as well, the recommendation is to treat the primary diagnosis first. So that's the diagnosis with the most functional impact. Step 2, low intensity psychological intervention. So this predominantly is CBT, which has started over 6 weeks. Individual guided self-help, which tends to be a CBT-based workbook or online course that can be done with a therapist on hand to kind of guide through that. And then also psychoeducational groups. So usually one trained professional to 12 participants, roughly 2-hour sessions for 6 weeks. For step 3 of anxiety management, we'd be looking at high intensity psychological intervention. So that's more CBT and applied relaxation, and then also pharmacotherapy. So first line SSRI is sertraline. So just to recap on SSRIs, it's reducing the amount of serotonin that is uptaken back into the presynaptic neuron, therefore increasing the amount of serotonin available in the synaptic space. Alternative SSRIs, paroxetine and escitalopram, and then SNRIs, duloxetine and venlafaxine. Again, you want to be cautious when you're starting these SSRIs. It's the same medication and same mechanism as with depression. So reviewing in that first week, especially around increased anxiety, suicidal ideation, that type of thing, especially in younger adults. Review the efficacy every 2 to 4 weeks for about 3 months, and then review 3 monthly after that. Side effects of SSRIs include in early treatment that increased anxiety and agitation I've already spoken about. And then you can also have GI side effects as well as some impact on sleep too. Some people get more tired, some people struggle with falling asleep. Antidepressant discontinuation syndrome is something that patients can be concerned about. SSRIs themselves are not addictive, but discontinuing SSRIs needs to be done alongside obviously a clinician and medical input. Antidepressant discontinuation syndrome has got quite a nice acronym for remembering the symptoms of stopping SSRIs quite abruptly. So that's flu-like symptoms, insomnia, nausea, imbalance, sensory disturbances, and hyperarousal, with the acronym FINISH. Best really is to taper off these SSRIs over several weeks or even months, depending on the dose started at, and yeah, taper alongside medical advice. Benzodiazepines can also be used to manage anxiety. To be honest, they're only really offered in primary care for short-term use because they're highly addictive. They have a slightly different mechanism of action to SSRIs and SNRIs. They enhance the binding of GABA to its receptor. So GABA activates that chloride ion channel on the postsynaptic neuron, allowing chloride ions to come in and hyperpolarize the membrane potential. So reducing the excitability of that neuronal synapse. Going on to some of the more niche and special cases, looking at pregnancy and the use of SSRIs and SNRIs. The advice is to use high intensity psychological intervention where possible, and discuss where SSRIs are needed, the medical benefits and risks associated. If a woman conceives while on an SSRI or SNRI, could be worth discussing with her the potential of switching to a psychological intervention while also balancing risk of relapse. I've just finished my obs and gynae rotation, and there's some really good advice that actually, you know, the most important thing for a ship, like if the mother is the mothership, is to look after the mother. If the mother's not well and isn't going to be feeding herself, sleeping, that kind of thing well, then she's not going to be in the best position to be caring for and developing her baby at that point. So priority really is looking after the mum and the mum's health, and following on from that, weighing up the benefits and risks to the pregnancy. So risks of using SSRIs and SNRIs in early pregnancy might include congenital malformations, for instance, heart defects, in that early pregnancy. However, the evidence on this is inconclusive and it's not super hard, fast, and set. So, you know, consider the health of the mother, the mental health of the mother, absolutely primarily in these cases. Beyond 20 weeks, the consequences or potential risks to the fetus mainly include persistent pulmonary hypertension of the newborn and or neonatal withdrawal once the neonate is born. Again, seeking specialist advice around switching SSRIs and SNRIs, or any uncertainty around medications in pregnancy. BUMPS is the website to be using for having for looking at medications and which medications and aren't licensed and safe during pregnancy, and obviously checking with the midwives and the obs and gynae team. Pediatric depression may well present with more physical symptoms than necessarily the child presenting themselves with a mental health problem. So specifically headaches and abdominal pains and GI issues. Whereas in adolescence, the presentation may be more likely to be around mood swings, difficulties with relationships, and behavioral changes. Treatment for pediatric depression for mild depression is watchful wait with 2-week follow-up, considering CAMHS and educational professionals, especially if there are any instances of bullying that might be contributing to that depression. If unresponsive to psychological intervention in the first 2 to 3 months, again, a review with CAMHS. For moderate to severe depression, we'll be looking at CBT for 3 to 6 months. And if unresponsive to that, then consultation with the MDT. For 5 to 11-year-olds, fluoxetine is recommended, but only with caution alongside psychological intervention. The evidence on that isn't fully established yet for fluoxetine in 5 to 11-year-olds. So best to discuss with a senior team. And then for 12 to 18-year-olds, fluoxetine alongside psychological intervention. My understanding is that fluoxetine is recommended over, for instance, sertraline and other SSRIs because fluoxetine has a longer half-life, therefore it doesn't necessarily need to be taken at exactly the same time every day, which can be difficult to achieve with some pediatric patients and adolescents. Psychotherapy is a super important aspect of treatment for both depression and anxiety. I've outlined here 5 of the key main ones, so I'll just go through them briefly. So CBT addresses unhelpful patterns of behavior. It usually involves some kind of homework, so tasks for the patient to complete in between sessions, and is usually 5 to 20 sessions of around an hour each. They tend to be quite toolkit based and focusing on readdressing thought patterns, really delving into them and finding patterns and techniques to be able to move forward. Guided self-help can be more of an independent approach, working through a textbook or a computer-based course, and again, develops tools and techniques to use beyond having finished that course. Behavioral activation as a talking therapy helps increase motivation to taking small practical steps towards recovery, and also includes problem-solving skills to tackle anything that's making mood particularly low. This can be either one-to-one or group-based or over the phone, and is usually 16 to 20 sessions. Counselling is slightly more free-form talking therapy to the others. It can range from 1 session to several months, and the NHS may well recommend 1 session through to several months. Counselling is also particularly recommended, for instance, in cases where fertility might be a problem that is exacerbating the mental health condition. Interpersonal therapy addresses problems with relationships and family, as well as close friends, where depression might be worsening those relationships, or equally where those relationships might be impacting that person's mental health. Particularly useful in mild to moderate depression, or if it hasn't responded to other therapies. And then EMDR is quite specifically for PTSD, and helps to reprocess memories of a traumatic event. So to reduce the impact of negative images, emotions, and feelings, and help with grounding. So EMDR in itself can be quite a distressing process. So is usually recommended after a particularly traumatic event or series of events has ended, and requires a good support network. So you need to be in a stable place in order to go into EMDR really in the first place. But it has been proven to be very, very successful. Usually requires 8 to 12 sessions. Suicide risk assessment is obviously at the more acute end of the spectrum for both depression and anxiety. Most important is to identify risk factors, but the protective factors are also super important. And highlighting those protective factors when you're doing a risk assessment can really help you differentiate between, okay, what are you going to be able to draw on here to be able to help a patient, as well as identify what puts them at risk. So looking at the risk factors, age with self-harm peaking between 16 to 24-year-olds in women and 25 to 34-year-olds in men. And then suicide rates being highest in the late 40s for both men and women. Socioeconomic disadvantage and social isolation. So unemployment, stressful life events, bereavement by suicide is a particularly poignant one, and coexisting mental health problems, including alcohol and drug misuse, chronic physical health problems that can be contributing to the mental health problems, especially chronic pain, and then involvement with the criminal justice system with specific focus on people who are in prison or are going through the criminal justice system, need particular support around their mental health, and especially should be flagged on a suicide risk assessment. Screening tools for suicide risk assessment, found particularly interesting analysis. So there was an article that draws on several different meta-analyses, but there are various different assessment tools, none of which should necessarily be used as a means of allocating treatment when someone presents with suicidal ideation or suicidal risk. There are over 156 different risk assessment tools that were found to be being used in the UK alone, and they're used with pretty poor consistency between them. So really looking forward for potential research in the future and being able to standardize some of these tools and use them more consistently might give us some better outcomes here. Positive impacts of using risk tools obviously facilitates communication and enhances therapeutic relationships and enables us to see may enable us to stratify people that need more acute safety netting and acute care compared to people that might need more long-term follow-up. But then negative views include inadequate training with use of the tools, and some of them can be very time-consuming as well. I think this is the last couple of slides. So emerging trends and research directions, some of the more novel treatment modalities, especially in the Oxford Trust, are use of ketamine therapy, which is usually 3 to 6 infusions over 6 weeks, so quite intensive therapy there. But around 50% respond well and want to continue treatment. Some have unpleasant experiences with the first infusion, but beyond that, the remainder is pleasant or neutral. And although the majority relapse at some point, they do tend to respond again with further treatment. And treatment over several years may be needed. The other key, more novel treatment is repetitive transcranial magnetic stimulation. So this draws on some of the more newer research into the neurobiology of depression, which is around neuroplasticity, so the ability of neurons to make connections with other neurons, and adaptability of those synapses and ability to form new synapses, rather than focusing necessarily on the serotonin, dopamine, noradrenaline aspects of it. So a little image on the right there shows that it's a targeted therapy. So it's this black tool on the side of the head, which stimulates a specific region of the brain, meaning that the side effects can be less systemic than, for instance, use of SSRIs. And often the sessions only need to be under 10 minutes, but they are for 5 days a week for 4 to 6 weeks. So intensive therapy, but more targeted, and possibly with less side effects. Our last slide here is on mental health in the medical profession. So this AAMC article is focused on the States, but it's a crucial issue in the NHS as well, leading to the NHS developing their own prevention of suicide, essentially booklet for employers, given the rates of depression and anxiety amongst medical students, junior doctors, and consultants, given the work pressure that we're under. And this one, this slide is predominantly to flag that sometimes it's particularly difficult for clinicians and people in the medical profession to view themselves as patients. So even looking at the third bullet point here, October 2020, despite 87% of emergency physicians feeling more stressed due to COVID, only 45% said that they didn't feel comfortable seeking treatment. So really important to look after each other, look out for the symptoms, both in yourself, in your peers, and in your colleagues. And then if you feel that you do need help, then contacting your GP and being supportive of other people. So for trying to reduce the stigma around mental health for patients and also for each other. And I've got the links here. These are all hyperlinks, all these underlined bits. So if anyone needs help or support, even just after this talk, then please reach out. I think that's all that I've got lined up here. Does anyone have any questions? Okay, great. So thanks for joining, and I'll if you do have any questions, then get in touch with the OSME people. I'm happy to have further discussion on the topics, but I'll stop the recording there, and thank you very much.